This could be tumors or dysplasias. Tumors could be non-aggressive, slow-growing, lack the ability to invade neighboring or distant tissue, and they are termed as benign. On the other hand, they could be aggressive, moderately or rapidly growing, and able to invade neighboring or distant tissue, in which case they are termed malignant. In view of the complexity of the oral and maxillofacial region, jaw tumors in the region could be termed as either benign or malignant in behavior, epithelial, mesenchymal, or ectomesenchymal in tissue of origin, or odontogenic or non-odontogenic, depending on their relationship to tooth-forming tissues. Tumors originating from the teeth or tooth precursors are termed odontogenic. As a contribution to general health, we consider the paucity of data on tumors and tumor-like lesions of the oral and perioral structures of Nigeria. I will now describe the challenges in the management of oral and maxillofacial tumors, using the giant ameloblastoma as an example. The ameloblastoma is a rare, slow-growing, locally destructive, but mostly benign odontogenic tumor that occurs worldwide. As an odontogenic tumor, its origin has been attributed to the enamel organ, remnants of the dental lamina, lining of dental cyst, and possibly basal cells of the oral mucosa. How these transform to ameloblastoma is not exactly known, but most patients present with the condition while aged between 20 to 40 years, and there is no sexual predisposition. It is more often seen in the lower jaw than in the upper jaw, especially the posterior region of the jaws. Patients with the jaw condition often describe a painless, progressive jaw swelling, causing displacement and mobility of teeth. Due to its painless nature, among other reasons, many patients present for treatment late, particularly in low and middle-income countries like Nigeria. Some present with giant, extensive, extreme, massive, or gigantic jaw swellings. We published a case report to illustrate the challenges involved in the treatment of similar lesions in our environment. The patient on your screen presented with a 10-year history of progressive jaw swelling that was disturbing his speech, feeding, and appearance. Reasons for his late presentation was ignorance of his health condition, as he was applying anointing oil to make the swelling go down. And he also indicated inadequate financial resources for treatment. The computerized tomographic image showed a massive swelling of the lower jaw with destructive perforation of the bone in several places. At resection, the lesion measured 48 centimeters by 38 centimeters by 17 centimeters, making it one of the largest jaw lesions to be surgically removed worldwide. Due to the limited financial resources available to the patient and the lack of technical facilities for microvascular bone graft replacement of the excised jawbone, he was treated using a titanium reconstruction plate to keep the facial form while he went to gather funds for the rest of his treatment. Ideally, after the bone reconstruction, you should have had a pre-vascularized bone flap and rehabilitation with implant retained prosthesis to carry teeth. The post-operative appearance of the patient with the available treatment is as follows. Incidentally, when he came back for review, the man had applied bleaching cream from head to toe. The provision of universal health coverage, including for dental services, will improve financial access to care, while improved health education will reduce ignorance. This will combine to encourage citizens with dental complaints like jaw swellings to present for care early, as the financial hazard of hospital treatment costs will be drastically reduced or absent. Also, there will be better awareness of treatment options. The clinicians will then be able to prescribe and conduct less radical treatments, reducing overall treatment costs and the post-operative consequences of treatment. In our opinion, this patient has had suboptimal treatment with lower prospects of adequate dental functioning, as dental prosthesis cannot be fitted in his present state. Hence, his speech, mastication, and facial appearance can be markedly improved with further treatment. At present, no center in Nigeria has the facilities for free microvascularized bone flap reconstruction of the jaws, while dental implantology is presently available, though financially costly. To provide the standard treatment some of our patients require, we need improved technical expertise on the part of surgeons, nursing, and laboratory staff, as well as improved treatment facilities. Oral cancer. Cancers of the head and neck could originate from the sinonasal, nasopharyngeal, parapharyngeal, hypopharyngeal, laryngeal, and otologic regions. Other possible sites are orbital, thyroid, parathyroid, salivary gland, and other lesions. As in other studies, we found out that squamous cell carcinoma is the most prevalent carcinoma involving the head and neck region. There has been increasing tendency for oral cancer to present in younger persons and females. Hitherto, oral carcinomas were generally a disease of the elderly and males. Reasons for this demographic shift include earlier indulgence in alcohol and tobacco consumption, especially before the age of 16 years, and infection with the human papillomavirus. Young people need to be strongly educated against acquiring and indulging in deleterious habits like tobacco and alcohol use, while vaccination against candidate strains of the human papillomavirus should be strongly considered. The relationship between oral health and adverse pregnancy outcomes. There is accumulating evidence that poor oral health has implications beyond the mouth, complicating mental health, diabetes mellitus, cardiovascular diseases, and compromising pregnancy outcomes, to mention a few. While the profound hormonal and physiological shifts experienced by pregnant women are necessary to maintain the unborn child, dental complaints could be worsened by pregnancy. A systematic review has also shown that periodontal diseases could contribute to the delivery of preterm low birth weight infants. Most of the available studies on the relationship between oral health status and adverse pregnancy outcomes are from high-income countries, whereas we know that several oral health challenges exist among pregnant women in sub-Saharan Africa. It is also known that the oral care of expectant mothers in sub-Saharan Africa is often neglected, and the prevalence of adverse birth outcomes in low and middle-income countries is also higher than in high-income countries. To better understand the situation in sub-Saharan Africa, we undertook a scoping review to explore the available literature on the association between oral diseases and adverse pregnancy outcomes in the sub-region. We sought to determine the reported associations between various oral diseases and adverse pregnancy outcomes, to identify gaps in the published research with a view to making recommendations on areas for further work. From the 15 articles that met the inclusion criteria, we studied a total of 5,845 pregnancy outcomes. Periodontal diseases were linked to the delivery of low birth weight, preterm birth, and low birth weight and overweight babies. It was also linked to preeclampsia and chorioamnionitis. The sequelae of caries was linked to some adverse pregnancy outcomes. However, some reports denied such links. 2 intervention studies showed that treating periodontal diseases during pregnancy reduced the risk of adverse pregnancy outcomes. The gaps in knowledge recognized from our review included the limited understanding of how oral diseases affected pregnancy outcomes, and the extent of oral care services available to pregnant women in sub-Saharan Africa. We also saw health organization. When analyzing the economic impact of preventing and treating oral disease in Nigeria, the estimated total expenditure on dental health care in Nigeria was equivalent to $137 million United States dollar, but the per capita expenditure on dental health care was equivalent to a meager 0.7 United States dollars. In terms of loss of productivity due to the 5 common oral diseases, it was estimated that Nigeria lost the sum of $835 million per year due to poor oral health. This is the amount we could save by improving oral health care services in Nigeria. At present, oral health screening for the early detection of oral diseases, facilities for emergency care and pain relief are not available to many Nigerians. Basic restorative dental services to treat existing tooth decay are also not available to most people. The human and other resources available for the provision of oral healthcare services in Nigeria are skewed in favor of urban centers, while most of our predominantly suburban and rural dwellers lack access. Even in the urban and semi-urban parts of Nigeria, despite the fair dental awareness described in the earlier study, most of our people have unmet dental needs. Those who are literally forced to attend dental services do so because of severe pain, gross swelling, or has emergencies for trauma. Despite over 20 years of the operationalization of the National Health Insurance Scheme and various state insurance schemes like the Ondo State Health Insurance Scheme tagged oranges, most Nigerians still do not have full coverage for essential oral health care services. Existing public schemes at the national and state level largely provide limited coverage for oral health services and mostly for public sector workers. Oral health services are known to be costly and beyond the means of most people in low and middle income countries like Nigeria. This means that most Nigerians will pay for essential oral health care services out of pocket, and the prospect of incurring catastrophic health expenditure when they need treatment for conditions like major maxillofacial trauma, congenital malformations, or neoplasms. One of the objectives of the WHO Oral Health Strategy 2024 is to integrate essential oral health care into primary health care and ensure related financial protection and essential supplies. Unfortunately, in Nigeria at present, oral health care services are poorly integrated into general health care services. Therefore, a policy framework to ensure universal health coverage, including essential oral health care services, and integrating same into primary health care is needed in Ondo State and Nigeria in general. The Ondo State government has already initiated moves towards integrating oral health into universal health coverage, but needs to harness the involvement of all stakeholders in the effort to achieve success. This must include concerted and massive public enlightenment of the residents in the state of available services and the benefits of accessing them using the coverage provided by the government under the Health Insurance Initiative. Professional dental education. The future of various professions and even human society lies in the quality and character of the students and youths of today. For us to retire and age responsibly, attention must be paid to the training of the future healthcare providers by our health institutions. Various medical and dental undergraduates intend to specialize later in their careers. In Anglophone West Africa, the United States and the United Kingdom, medical and dental clinical specialization is through the residency training program. However, the program is not altogether rosy. In a survey of general study residents in the United States, 20.5 felt that the duration of training of 5 years was too long, while 15.3 had considered leaving the program within the past year. Before COVID-19, a review of the prevalence and causes of attrition among surgical residents in the United States estimated the attrition prevalence as 18%. In some high-income countries, after COVID-19, there has been substantial and persistent increase in the turnover of healthcare workers, which suggests that less workers will remain in the sector in succeeding years. While formative and summative examinations in various forms test competency, there is continuous need for the evaluation of expectations, attitudes, experiences, and perceptions of trainees. Such will improve the training curriculum, enhance satisfaction with training, decrease attrition, and positively impact healthcare delivery. Nigerian medical residents complain that their consultants contribute less than 50% to their training. They also list the challenges of the poor state of training facilities and low remuneration package, among others. The hierarchical nature of the medical and dental education and practice, which is akin to military practice, means that the exploration of the professional experiences and training attitudes of residents in dentistry will be beneficial. The immediate stimulus for this study was a cartoon that was shared on the WhatsApp chat of my alumni association, the Benin University Dental Alumni Association, where the oppressor, that's the person with the big foot, was the medical and dental consultant. And the last person that you almost are not seeing is the house officer. When this picture was shared, I said, it is not so bad. So somebody said, you don't know anything, it is worse. Apparently, the person didn't know who said it was not so bad. So when later somebody corrected him, he said, Chief, I'm sorry, it is very bad. This informed our design of a cross-sectional study to evaluate the expectations, experiences, perceptions, and attitudes of dental surgery residents towards residency training using a modification of the tool that was used in the United States. We covered all dental surgery residency trainings as at 2015. We found that there were more males than females, ratio 1.9 to 1. 41% were between 30 and 34 years, and 77.4% were married. While the general Nigerian population is slightly skewed in favor of females, their underrepresentation in the dental residency training program poses questions about equity and the need to resolve factors hindering females from specializing in dental surgery. Also, more Nigerian residents were older with marital responsibilities. In the United States, about 47% were between the ages of 30 and 34, but only about half were married. In our study, among the specialties, oral and maxillofacial surgery residents expressed a low level of satisfaction with the quality of training. Most, 65%, felt that the residency training took too long. Overall, our study showed that dentistry residents in Nigeria had low level of satisfaction with the quality of their training, and that they requested for more didactic lectures as is done in the United States and the United Kingdom. The conduct of trainers also needs improvement to tackle some of the demotivating factors. The challenges facing the production of the next generation of medical and dental specialists for the increasing Nigerian population is now being further worsened by the JAPA phenomenon, whereby skilled healthcare cutting across all categories are migrating from Nigeria to seek greener pastures abroad. In 2019, the Department of Oral and Maxillofacial Surgery at our affiliated teaching hospital had 7 residents, but today the department has only 1. Some units at the teaching hospital have only consultants in the team with no residents. Even our young graduates are joining the migration train. The implications of this shortage are already manifesting, but will get worse if something is not done quickly to stem the tide. The push and pull factors of this migration are well known, but implementing the suggested solutions seems to be taking too long. Our federal and state governments need to urgently tackle the push factors of insecurity, high cost of living, projector, high cost of living, and high rate of taxation of personal emoluments. In 2024, the Federal Ministry of Health launched the National Health Workforce Policy, a national policy to retain health workers and attract those in the diaspora to return. Healthcare workers, like health, respond more to social, economic, and commercial determinants rather than exclusive incentives. Hence, policies that are targeted towards reducing JAPA will not achieve much without improvements in security, the living standard and conditions of the average Nigerian citizen residing within the country. My service to the community. Within my period of service at this university, I've been acting head of department, acting director of academic planning, acting dean, and I've also chaired various committees. I currently serve as the chairman of the Committee of Deans, and I'm also the chairman of the Business Committee of Senate. As acting director of academic planning, under the leadership of the incumbent vice chancellor, this university secured verification of 11 new academic programs by the Nigerian Universities Commission. As part of that verification, our university is the only one in Nigeria training the highest variety of professionals in medical rehabilitation and dental sciences. Our Faculty of Dental Sciences is the only tertiary institution in Nigeria to date that is training 3 categories of dental professionals: dentists, therapists, and technologists. My colleagues and I in the Faculty of Dental Sciences have also contributed to the human resources for health by ensuring the induction of 3 sets of dental surgeons. Having described the research and community contributions made over the years to ensure that oral health of man is improved, both as a dental surgeon and as a maxillofacial surgeon, I recommend the following: that government should increase investments in the social determinants of health, such as housing, food supply, water supply, and sanitation. The government should ensure the implementation of universal health coverage to improve equity, thereby contributing to the achievement of the health-related sustainable development goals. That we should integrate essential oral health care services into primary health care and integrate oral health into various public health programs. That the delivery of primary oral health care services, especially in the rural areas, should be pioneered through the training and deployment of dental therapists, community health officers by state governments. Public health enlightenment to inform citizens about available services and the benefits of accessing them under government initiatives. There should be integration of oral health care services into maternal care services in sub-Saharan Africa. In conclusion, Vice Chancellor, sir, distinguished ladies and gentlemen, the oral health of Nigerians, including the residents of Ondo State, needs improvement through policy measures at various levels. While the level of oral health education in the state is fair, there is unmet dental need, manifesting in late presentation of patients for treatment, inequitable distribution of health infrastructure that favors urban over other areas, and the high cost of dental services and poor access to oral health care services. There is need to make the Nigerian pastures green so that healthcare workers will remain in Nigeria rather than migrate. As a maxillofacial surgeon, I believe I have contributed towards the advancement of knowledge and assisted by providing healthcare services and training, thereby improving the oral and general health of the Nigerian population. Acknowledgements. I'm grateful to God for today, for life, for family, and all those who have contributed to the journey so far. Again, I thank the Senate of the University of Medical Sciences, the management, and all the staff for giving me the opportunity to stand before you as an inaugural lecturer. I thank the Vice Chancellor, Professor Adebayo Fatusi, Fellow, Nigerian Academy of Medicine, and Fellow of the Academy of Science, for his leadership and mentorship. He persevered in encouraging me to deliver this inaugural lecture. I'm also indebted to all my colleagues in the Committee of Deans, members and students of the Faculty of Dental Sciences, and the Department of Oral and Maxillofacial Surgery for both the hospital and the university. I thank my past teachers who did not give up on me. I remember the late Brigadier General Oshuntala, former Director of Dental Services of the Headquarters Nigerian Army Medical Corps, and former Chairman, Faculty of Dental Surgery of the National Postgraduate Medical College of blessed memory, who gave me a note to Kaduna. I also pay tribute to Professor Emmanuel Adebayo, now of blessed memory, who took me into the residency program. Other seniors like Professor Ezekiel, Dr. J.T. Amuda, and colleagues at the former Maxillofacial unit in Kaduna are warmly and deeply appreciated. I thank my parents, Chief Abraham Adebayo and Madam Felicia Adebayo, both of blessed memory. They sacrificed and toiled to ensure we went to school. I thank my wife, Hannah. She has been a covering. She has been a covering for my inadequacies, and I bless God for her. To our children, God's precious gifts